any questions or other things I can help with. And we'll be talking about thrombocytopenia in cancer use of thrombopoietin receptor agonists for management. And here's my disclosures. So thrombocytopenia, as we all know, is very common in cancer patients. This was from a paper about 5 years ago now. And we looked at the causes of thrombocytopenia. And I would say this is people who have thrombocytopenia more than 1 week, or a given day we're not concerned about. But by far the most common is chemotherapy. Mixed causes is typically chemotherapy and something else like infection, sepsis, other drug reactions. Malfiltration and myelophysis is known to be an issue. And the other graph shows when you mix pictures, by far chemotherapy is the most common. And this is shown for a gentleman, your prostate cancer, 60-year-old patient I took care of. And it's just showing his CAT scan of his target bones, and you can see the red rock eaten. So patients who have extensive bone metastases sufficient to see cortical bone destruction, you know they're going to have pancytopenia, and because they're simply replacing the marrow with malignant cells. And those patients are very problematic. We're talking a little bit about it later. But again, that's not most of the we're talking about patients who have preserved marrow space, have minimal or don't have extensive bone metastases, and therefore have the capacity to make blood cells, if not for the chemotherapy induced suppression. This is just showing some peripheral blood. We're all hematologists and hematology oncology doctors, and this is what we see in the peripheral blood of a patient who has bone metastases or bone marrow infiltration for any reason. So see, let's shift the white cells through the red cells. And these are the same, these are peripheral smears from actually the patient I just showed. This is from maybe about 10 years ago, but it's a very illustrative case. And this is just showing when you do a bone marrow biopsy in a patient like that, we're going to see these malignant cells. So this is a sort of a side issue. What we're going to focus now on is classic CIT or chemotherapy-induced thrombocytopenia. And I'm just going to call it CIT in the interest of time. There's really a couple of ways we have to think about CIT and care about it. If it's very severe, of course, patients will be bleeding. And that's most common with induction therapy for AML, post-stem cell transplant. But most of the time, what the oncologists are dealing with is the need to reduce the dose intensity of therapy to avoid getting to a severe thrombocytopenic stage. So this is what we call reduced relative RDI. Relative dose intensity means you're delaying the chemo or reducing the dose of the chemo because of the thrombocytopenia. And obviously the concern there is, does that impact cancer outcome? As I said, it's pretty rare that solid tumor patients, and even most malignancy patients, are bleeding from thrombocytopenia. The current literature supports the idea that until the platelets get below about 10,000, maybe 20,000 if there's some additional risk factors. But until the platelets get very low, patients don't bleed spontaneously. But the key for the oncologist is to avoid getting it, to avoid having the thrombocytopenia so low, which is why we have guidelines about when to modify and reduce the dose intensity. Platelet regulation is mostly under the control of thrombopoietin or TPO. Thrombopoietin is made in the liver. It's a growth factor made in the liver. Excuse me. And our current understanding is it's made constitutively. It's not turned on or turned off, depending on thrombocytopenia. It's made constitutively. However, it binds to megakaryocytes in the bone marrow, but it also binds to platelets in the peripheral blood. So if the patient has a normal or high platelet count, then the thrombopoietin will bind to the platelets, not be available to bind to megakaryocytes, and therefore one will turn down thrombopoiesis, one will turn down growth differentiation of megakaryocytes and platelet production. If the patient has a low platelet count, then thrombopoietin will have less platelets to bind to, more will be left over to bind to increased production of platelets. So it's sort of a negative feedback loop that influences. So recombinant thrombopoietin was made about maybe 20 years ago, I forget exactly, 20, 25 years ago, and it was being developed by Amgen. And unfortunately, what happened was some of the normal volunteers receiving some of the forms of recombinant thrombopoietin developed cross-reacting antibodies that were quite devastating. They cross-reacted with the endogenous thrombopoietin, leading these normal volunteers to be significantly thrombocytopenic. And that halted all further development in the Western world. The only place recombinant thrombopoietin is still being developed is in the People's Republic of China. I've seen some literature coming out of there. It does seem to have activity, but I haven't seen enough to convince me that we should readdress use of recombinant thrombopoietin. So when recombinant thrombopoietin led off ceased being developed, a number of companies started working on recombinant or oral small molecule thrombopoietin receptor agonists, or TPO-RA. And the TPO agonists, there's 4 that are currently available anywhere in the world. Romiplostim is a peptide, which means it's a peptide linked to an Fc domain. Romiplostim will bind to the thrombopoietin receptor, but the peptide does not mimic the actual structure of TPO. So it mimics it, but it doesn't. There's 3 small molecules, all of these are available in your country, but trombopag, trombopag, and lucid trombopag. These are all small molecules trying to activate the TPO receptor, also called ZEMOL. Many of these can activate the TPO receptor and turn on megakaryocyte proliferation and differentiation of platelet production. I'm not going to show all the different steps, but this is the primary growth factor of TPO, and these drugs all work by turning on that receptor. So we're going to focus, these drugs are FDA approved for ITP, thrombocytopenia. We're not going to talk about that. We're going to talk about CIT, which is obviously very near and dear to all of our hearts. And I want to emphasize there's really 2 ways of considering CIT. One is persistent CIT and one is native CIT. And the literature has been a bit foggy, a little bit inconsistent, because people are developing studies with different eligibilities and different endpoints. So they're going to get very different kinds of results. So let's briefly tease this out. Persistent, or why I use the word persistent CIT, is simply a patient who's getting chemotherapy and whose platelet count does not recover sufficient for the next cycle on the day that cycle is scheduled to start. So we all see these. Somebody's getting, they have pancreatic cancer, they have gemcitabine-based regimen, the platelet count comes up, it's hovering around 70,000, and it's a little low to start the next cycle. So we'll typically wait a week, we'll have to do something. And if the platelets simply don't come up, then the oncologist is forced to reduce the dose. Nadir CIT is different. Nadir CIT is simply saying that the nadir of platelet counts is lower than we want, it's lower than we anticipated, and puts the patient at risk of bleeding, and it means that we also may need to give the patient platelets. Platelet transfusions are helpful, but they're only a very short period of time. They're a limited precious resource. Normal people have to volunteer to donate their blood or sit on a pheresis machine for several hours to get the platelets. So it's not really an intermediate to long-term solution. It's a good solution if there's an emergency, but otherwise it doesn't allow us to support the platelets through a course of chemotherapy. So the impact of persistent CIT is typically reduced dose intensity of chemotherapy. This is sort of a very important paper from 2014 now from Japan, Nakayama et al. And they looked at colorectal cancer patients who had to have a reduced relative dose intensity of their chemotherapy. This is not only from CIT, this is from all causes of reduced dose intensity, but it still illustrates the point. As I said earlier, I'm dealing with a cold, so I pardon for coughing. But what they showed is if the patients received a really moderate dose reduction, only 20% or more dose reduction of their chemo, it was associated with a highly significant worsening of progressive and also worsening of overall survival. These are things that cancer patients clearly care about. Both of these were under 0.1 or 0.01. So this is kinds of data specifically for dose reduction for CIT. But it's not a big stretch to extrapolate that reduced IDI of any cause would be adversely impact the patient's outcome. There was other reasons for reduced intensity. It could be sepsis, it could be failure to thrive. So those patients may not be exactly matched. But I think you get the point that we really care about preserving RDI. So I want to emphasize here, this is the point. What is the goal of treating CIT? Obviously, we want to avoid bleeding, and we want to maintain full dose therapy because we believe it has a favorable impact for the patients. But that needs to be proven prospectively, not retrospectively. But the expectation is, and this is what my ongoing clinical research is focused on, can we identify a population and a treatment strategy where addressing CIT will prospectively improve progression-free survival? I think that's the critical next step. And that's what I'm hoping to do the next clinical trials on. And lastly, I would emphasize that we'll come back to the NCCN at the end, because NCCN does endorse use of Romiplostim for CIT, but the FDA and European Medical Association do not currently approve any treatment for CIT except for supportive care. I don't know what the regulatory state is in India, if your regulatory body approves it or not. I apologize. So I started working on this in, I think about 2011, the very first patient I treated. And it was I still remember him well, he was an 80-year-old gentleman, but extremely fit, extremely active, who had metastatic colorectal cancer, and his platelets were down in the 30s and 40s for months, probably because of extensive liver metastases. And he was fit, but his tumor started to grow, and the oncologist had nothing to offer, so he reached out to me. I said, well, Romiplostim was recently FDA approved. We used it off-label, but it was justified and authorized. And his platelets shot up, and he resumed chemo, and he stayed on chemotherapy for 3 years. This was a gentleman with heavily pretreated colorectal cancer for 3 years when he was in his 80s, and only once at the very end of life did he even require hospital stay. So that was a pretty good outcome. So we published our first paper in 2014. One of my colleagues from Kelly, when I was still there, Dr. Swarn. I think she's originally from Chennai. I was asking about that earlier. And we did a series of 20 patients, and we showed very clearly that you can see that once we started the Romiplostim, the platelets came up beautifully. The reason it didn't keep going up is we resumed chemotherapy, and we were titrating the platelets for a goal of approximately 150,000. So this worked perfectly. I really, 19 out of the 20 patients had a perfect response, and this was extremely gratifying. And it led us to then consider doing a prospective randomized clinical trial, which is what we did here. This was started in 2013. And it was a very simple study design. It was a phase 2 randomized design. Patients had to have solid tumor metastatic disease, no chemo for the past 14 plus days. We didn't want to simply get patients who were already recovered from their neighbor. We wanted patients who had persistent CIT. So they had to have platelets under 100,000 for 4 weeks. They had to have these relatively preserved ANC and hemoglobin, shown here. And the patients were randomized 2-to-1 to Romiplostim weekly, titrated, versus observation. So it was open label. The primary endpoint was to collect the platelet count to over 100,000. So one of the things we did is, this is open label. These are people, patients whose lives depend upon being able to tolerate the therapy, being able to get the therapy. So we built in a crossover. So a patient who was randomized to observation, they would never stay on the study. they were basically not going to get it. So after 3 weeks or failure of their platelet count to recover, they were eligible to cross over and get nuclear Romiplostim, and then we followed them like everyone else. And the results were quite gratifying. This is a illustrative of one of the patients. This was a 33-year-old gentleman with metastatic colorectal cancer, heavily pretreated, whose platelets were simply going too low to resume and maintain chemotherapy. He was getting 5 FeNO, and you can see there's gaps here. The oncologist held, they tried to treat, those platelets continued to drift down. We reduced the dose, and the platelets continued to drift down. So he enrolled in the study. He started with Romiplostim shown here. His platelets came up perfectly, and he was able to resume full dose chemotherapy on time, on schedule. Like many of his patients, he did have metastatic disease, and he's not going to be cured, but he lived 3 years on therapy with a pretty good quality of life. Of course, when you're in the 30s, 3 years doesn't sound sufficient, but it showed at least that the drug was working and allowed his oncologist to better control the disease. This is the results of the study. So here you can see the blue, the Romiplostim in front patients, and here in red, these are the observation patients. So most of the observation patients didn't do anything with their platelets. And then we were able to cross them over, and within 2 weeks, their platelets came up beautifully. So most of the patients, we strive to see a response in 1 to 2 weeks, almost everybody by 2 weeks, and almost everybody for sure by 3 weeks. So in my practice, in my recommendations, 3 weeks is a fair trial. Patient doesn't respond in 3 weeks, they're probably not going to respond. But fortunately, the overwhelming number of patients who met our eligibility criteria did respond. And that's important for a lot of things. If you treat patients beyond where the drug has been validated, you can't rely on a good response rate. And here's the results from the whole study. It was a 2 to 1. And after 8 observation patients, when the statistics were so overwhelmingly strong, we dropped the observation line. Everyone just got Romiplostim up front. And I cleared that with the IRB because I felt it was unethical to continue offering patients no treatment when we've already proven that treatment is safe and effective. But this is what we showed in the aggregate, the total population, that 44 patients, 85% of the Romiplostim patients responded within 3 weeks, and only 1 or 12.5% of the observation patients responded within 3 weeks. Some of the failures with Romiplostim were protocol violations. The oncologists did not hold off on resuming chemo as they were instructed to do. The patients still responded, but it was a little slower because they were getting chemotherapy, and that obviously delayed the full recovery. But on protocol, we have a 93% response rate. It's a beautiful, high response rate. The drug seems to be working good. We also wanted to see, can we maintain the platelets with resumed chemotherapy? So 44 of the patients were re-challenged with chemotherapy. Not everybody was re-challenged because they had surgery, a couple died. But the patients tolerated it very well. Only 3 patients had recurrent CIT. Other patients had other problems. Pancytopenia, that Romiplostim didn't address that. Non-hematologic toxicity. Obviously, in patients, a couple of patients died. But we didn't see any evidence of early resistance to the drug. There was about 10% had a venous abdominal molecule. 2 of them were simply calf clots. And these are solid tumor patients with metastatic disease on chemo. And most people would feel about 10% rate is sort of within the expected range. Recently, this past spring, we published an extension study. So patients who were responding and chose to were eligible to continue with Romiplostim for as long as they wanted, as long as they were alive and the oncologist wanted to give it to them. So we published this paper this spring. Here's a reference. One of the junior faculty side looked at this was the first author. I was the senior author. And 21 of the 44 patients remained on the Romiplostim for over a year. And during the study period, there was almost no CIT. 70% had no further episodes of CIT at all in over a year. sometimes up to 3 years. 4 patients had a single chemotherapy dose without the way you do CIT, and then went back to full therapy. And then there was one who had a chemo dose reduction. So there was no evidence of refractoriness, there was no evidence of resistance. And we have a number of patients who are doing this long term. My colleague and friend, Hani Al-Sankari at Massachusetts General Hospital, published a very helpful study as well. This was not a randomized trial. It's basically an institutional pathway. And the patients got Romiplostim on 1 or 2 different regimens. And he was basically looking at the recovery and maintenance of chemotherapy similar to what I did. And here's the regimen that I'm not going to walk through here, but patients got weekly dosing like I did, or intracycle, less frequent dosing, shown here. And you can see, as you would expect, that the weekly dosing was more effective than the intracycle because the patients are simply getting more frequent doses. But again, the patients came from about 60 to 70,000 platelets prior to enrollment to about 100 to 150 and maintained their platelet counts. Again, Dr. Al-Sankari's team also showed that the response rate was good, 71%. 80%, except 9%, almost 80% avoided chemotherapy dose reductions or delays, and almost 90% avoided platelet transfusions. He had a shorter experience, which is, but it was still very similar to what we had published ourselves. And again, there was very low bleeding and there was a low rate of thrombosis. So it appears to be safe and effective in both these 2 large studies from Mass General and my practice at Soff. We know now, Dr. Al-Sankari and myself, both showed the same categories of utility. I think this is very important. If the patients have bone marrow invasion sufficient to cause cortical changes from routine imaging, they will not respond to Romiplostim. So don't start there. Sometimes we say, well, I have to do something, but it's an expensive drug, it's a precious resource, and we shouldn't use it in patients where we believe it will not work. We should use it in patients where at least there's a reasonable chance it will work. Similarly, patients who got extensive pelvic radiation, like prostate cancer or ovarian cancer, they also tend to have a low response rate because they simply don't have the marrow space to produce the drug. And both of our experience, temozolomide seems to cause a much, in a minority of patients, but it can cause a longer, more protracted thrombocytopenia. Those patients also seem to not respond to Romiplostim. But barring these categories, assuming relative preservation of ANC and hemoglobin, you should be able to assume about 70% or higher response rate and continued ability to treat the patients with Romiplostim support. I would simply add that I usually do not try to stop the support unless the oncologist has changed the chemo regimen to something that was not previously associated with thrombocytopenia. I don't want to just talk about Romiplostim because I think it's important to recognize that these drugs are not interchangeable. And I'm not, I told you I've done research for Amgen, which makes Romiplostim. My friend Dr. Al-Sankari, he's done work with Romiplostim and the Romiplostim. But I want to go through these other drugs as well as solid tumor lesion. So there's a couple of studies, phase 2s with a Romiplostim, and there was a phase 3 with Romiplostim. These studies were negative for benefit. So I want to make an opinion. I think had some design issues. Asked biology. So this was from Kellerman in 2010. And this was Romiplostim versus placebo in patients receiving carboplatin paclitaxel for advanced solid tumors. So these were patients who had not already experienced cytopenia. So if you just look at the solid line placebo, it's a little small, but I had to try to get this onto the slide. 200,000. So the placebo patients started off around 300,000 platelets. Well, and what you see is with the chemotherapy cycles, the platelets never went below 200,000. So it's impossible to show an improvement in the platelet count when the placebo, with the drug, when the placebo platelet counts were already very good. So this is another very important point. At this point in time, this study and others, no study has demonstrated that prophylactic use of any TPO agonist is appropriate or indicated. If you don't select patients who have a clear need for intervention for CIT, you will have another one of these negative studies where the control population does so well you can't do better than that. And that's what we're seeing here with the Kelly study. There was a similar study a few years later by Weiner et al. This is in 2017, the International Journal of Hematology. And it was the same kind of thing. These are patients who had not already had thrombocytopenia. And if you look here about Romiplostim versus placebo, the counts are cycling very, very similar. Now, Romiplostim, the peak is higher. So when the patient's about to start giving chemotherapy cycle, indeed the platelets are higher than the placebo. But if you can read this number, this is 150. So the placebo patients have already fully collected their platelets more than enough to receive full dose chemo. So there was no added benefit of the Romiplostim. And if you look at the negative, they were almost exactly superimposed. So again, there is biological activity, but not at the time when we need it. They're not showing the negative is better, and they're not showing that in the placebo patients, the day one of a given cycle is insufficient for the cycle. So therefore, the drug couldn't show benefit because there was no need in the placebo population. And that's what we're currently doing. There was a phase 3 clinical trial of avatrombopag. To the best of my knowledge, this is the only phase 3 study that's been done. Mine was a phase 2. Dr. Oncology was sort of a retrospective quality assessment initiative. But this was the only phase 3 study. 122 patients were randomized 2-to-1 avatrombopag to placebo, and the patients had to have a significant native thrombocytopenia under 50,000 for 2 measurements during the nadir of the primary chemotherapy cycle. But patients who had 2 or more episodes of CIT in the past were excluded. So again, this is the same kind of a problem where patients who had the greatest need for intervention were excluded. And this was apparently at the request of the Food and Drug Administration. So again, this study was a negative study, as I'll show here. This is the same pattern we saw with the L-Traumapag study. This is avatrombopag, as I said. So the patients started off exactly the same. Patients' platelet counts came up beautifully. Avatrombopag was higher than placebo. But at both here and at the second cycle here, again, in the placebo patients, the platelets were more than adequate for the next chemotherapy cycle. So again, you can't do better than not needing the drug. And that's, again, the recurring theme in both of these studies. So I can't really conclude that in a different population, with a different study design, avatrombopag or L-traumapag would not be effective. I can simply say that with the data available to us, we don't have evidence that they will be effective. And again, so 70% of the avatrombopag and 73% of the placebo patients agreed the primary endpoint of avoiding platelet transfusion or chemotherapy dose reduction of the right. So again, the placebo patients are doing so well, it's very hard to do better than that. Fortunately, with L-traumapag, which I'm not showing you all the studies, avatrombopag, as well as Romiplostim in the solid tumor patients, it seems to be safe. We're not seeing a significant rate of thrombosis, and we're not seeing significant or other adverse events. The hematologic malignancies, unfortunately, the literature is less favorable. It's not just not sufficient, but it's actually suggesting that maybe deleterious. So we're talking about AML and stem cell transplant, high-risk MDS. Lymphoma is nothing has been completed and published. But we're going to talk about the AML use right now. So this is a paper from 1997 from Wetzler et al. And they looked at the thrombopoietin receptor, c-Nipple, in patients with AML. And this is quite striking. And JCO is an excellent journal. I think it wasn't getting enough attention because it's an old paper 25 years ago. So what they showed was, this is no treatment. This is long before there was a TPO drug, long before TPO was even identified. The patients who had the c-Nipple receptor on their blast, which is about half the patients, they had a much worse complete duration of complete response. So c-Nipple positive was 6 months, and c-Nipple negative was over 17 months. And overall survival was also notably different. It just missed statistical significance. So this marker, simply having c-Nipple on your blast, means that these AML patients have a much poorer prognosis. But with that in mind, why do we give a drug that would potentially activate the receptor when the receptor is harmful, right? So in my mind, when I talked to people over the years about this, I said, don't touch AML, maybe in the context of a clinical trial, but if I had AML, I would not enroll in these kind of trials because it's supportive care and to avoid transfusions. Obviously, you have to avoid bleeding, but it gives you a risk that the leukemia goes worse. That's really quite a bad message. So then this is just showing you data in graphic form. Complete remission survival showing how these curves diverge pretty quickly and remain diverged. So Frey et al. In 2018 published the first of these 2 studies. And these are patients with AML who were started standard induction chemotherapy. And they were randomized to high dose eltrombopag or placebo once daily. And they stayed on the drug until the platelet count was over 200,000 or until remission, or until 42 days after the start of induction chemo. And the primary objective was safety and tolerability. This is a phase 2. But the results were quite, not just disappointing, but pretty shocking. So if you look at serious adverse events, 32% in the eltrombopag versus 20% in placebo. More serious adversities in eltrombopag. If you look at death from all causes, there's a 12% higher rate of death with eltrombopag. Thrombosis was basically the same. So more adverse events and more death with eltrombopag, and it had no favorable impact on platelet count. So the safety signals were adverse, and the benefit signal was absent. So this is a pretty, I think, troublesome finding. A second study was done, the ASPIRE study, the mixed advanced high-grade MDS with AML and severe thrombocytopenia. It was a randomized controlled study, again with eltrombopag. And the study failed to show its endpoint of composite reduced clinically relevant thrombocytopenic events, hemorrhage, severe thrombocytopenia, so no benefit. But again, there were 2 fatal serious adverse events in the eltrombopag arm, 1 fatal arterial thrombosis and 1 MI, and the investigators felt these were probably study drug related, and none of those events were occurred in the placebo arm. So again, no benefit and significant concern about harm. So again, these are AML and high-risk MDS have only been studied with eltrombopag. I can't say romiplostim would be better. I can't say eltrombopag would be better. But I can say that there's a theoretical reason not to use TPO agonists in the setting, certainly not outside the context of the clinical trial. This should show the same thing. So my friend Mike Scordo and I published this year an open-label pilot study with romiplostim in patients undergoing autologous stem cell transplant. So this was we call it a pilot study because it was a single-arm study of historical controls. And obviously, patients undergoing auto transplant have significant persistence of CIT after the conditioning regimen, often need at least 2 or 3 units of bed cell of platelet transfusions. So can we improve that? Can we shorten the duration of the neighbor? One of the reasons I'm comfortable with this approach is because lymphoid cells and myeloma cells are not known to have the C-lymph receptor. So there's low risk, theoretically low risk, of stimulating the malignant clone after the transplant. So the study, I'll show you some of the results in a second, but the primary endpoint was to reduce the numbers of days requiring platelet transfusions or grade 4 thrombocytopenia compared to historical controls. And the secondary endpoint was to reduce the number of platelet transfusions alone and reduce the time to platelet engraftment and improve overall platelet recovery. We put in 60 patients, 40 myeloma, 20 lymphoma, and everyone got a fixed dose of 3 micrograms per kilogram post-transplant day 1, 2 micrograms per kilogram post-transplant day 8, and if, but only if needed, after day 15, any further doses. And this is just showing here the results. So green is the treated Romiplostim and red is the historical control. What you can see, we were disappointed, is that the depth and the duration of the neighbor is basically interchangeable. But starting around day 15, there was a significant divergence of the treated versus the untreated. But again, from a practical point of view, who cares, right? If by day 21, almost everybody's over 100,000 whether they got the drug or not, and that's where the discordance of the two curves starts, well, we're improving the platelets when it doesn't need to be improved. So this was a negative study, disappointing. But we clearly showed that the drug is active. So now, like in other situations, can we improve on action? And this is just showing the lymphoma and the myeloma patients separately, both giving us the exact same pattern. The counts later around day 7 to 10 and started to come up, and only after the counts started to come up did we see a divergence. And here's a little bit earlier. You can see maybe about day 15, 17, they start to diverge. But, not a great benefit, that's fortunate. And if we look at the total number of days of transfusion or grade 4, myeloma, lymphoma here, 6 and 11, historical controls 5 and 8 or 10, depending upon which conditioning regimen, no benefit, not even a hint of benefit. So again, this is educating us, and it's helpful, it's important, but it teaches us that we can't assume that the drug is going to work in all situations. Fortunately, we didn't see any adverse effect of neutrophil engraftment or platelet engraftment shown here. And this is something, I don't know if your labs routinely measure initial platelet fraction, but a lot of the big commercial companies now, when you get a CBC, they'll include the immature platelet fraction. It's sort of analogous to the reticulocyte count. And that's just shown here that the immature platelet fraction in blue leads the platelet recovery by about 6 to 7 days. Quite helpful. So this is like the ticket showing that the marrow starts to kick in by about day 5 or 6. So can we make this quicker or more robust? That's the next subject of research which I'm working on. And one unforeseen benefit was an improvement in the hemoglobin. I know we don't know if Romiplostim has been approved for severe aplastic anemia because it seems to have a beneficial effect on other lineages. And in this situation where patients are getting a myeloablative regimen, we actually did see an improved hemoglobin compared to with Romiplostim compared to historical controls. And that wasn't foreseen, but it's pretty good. We'll that into our new studies as well. So in conclusion, and I look forward to a discussion of questions, in the solid tumor patients, TPO receptor agonists are effective in treating persistent CIT in solid tumor patients, probably not needed for most early CIT, and this has only been shown so far with Romiplostim. TPO receptor agonist maintenance in persistent CIT again, only shown with romiplostim so far, allows the resumption of chemotherapy with a reduced rate of recurrent CIT. There's no evidence of a thrombotic risk. We would need very large numbers to have strong statistics, but so far we're not seeing anything of concern there. We don't have evidence yet of improved cancer control. We can't say the cancers have gotten worse, and anecdotally, the patients who I was treating for over a year, we did not see cancers taking off and growing aggressively, which is all very encouraging. And for futility, bone marrow invasion, particularly sufficient to see cortical bone changes, pelvic radiation, and paratenozoa. In heme malignancies, there's really no evidence to support it. I would say particularly AML and high-risk MDS, they may be harmful. In autologous stem cell transplant for lymphoproliferative neoplasm, it may be a benefit, but the data and the study design are not yet there. And lymphoma is simply parsing the data to draw any conclusion. And this is the current NCCN guidelines. It says basically, this is in solid tumor patients. You can consider a TPO agonist romiplostim, or consider clinical trial, which is certainly reasonable. And because of this NCCN designation, at least in the United States, one is able to prescribe romiplostim for CIT, and insurance will cover it. And that has definitely changed practice, in my mind, in a favorable way, but I would be anxiously waiting to see clear data that is favorably impacting cancer. And this is the last slide here. So I run an online hematology course. It's completely academic. It's free. It's free to everyone. It's a nonprofit. If you want to learn more about hematology, please go on the source. It's aimed at fellows. We have a couple of thousand fellows around the country, around the world, I should say, who log on to learn some hematology. I don't make any money, so I don't feel like I'm exploiting it. But if you want to learn more about hematology, please go to the course homepage. And that's all for now. So thank you very much. And I'm looking forward to discussions and questions with you all.
Thank you, Professor Soff, for that wonderful presentation. Learned a lot. I'm a hematologist, Dr. Agarwal, and I'm going to put the hematology to you. Number of these questions probably put in before you covered the hematology part of your lecture. So this may be at the cost of duplication. The first question was whether there is a fear of transforming a low-grade MDS to higher grade when you use Romiplostim to improve the platelet count in the MDS patients.
So that's a great question because I didn't go with everything, but people do use it in some patients with low-grade MDS to try to reduce platelet transfusion requirement. I haven't seen good data on large numbers to indicate whether it is or isn't transformation, but to the best of my knowledge, I have not seen it.
Right. The next question is, if you give the TPO receptor agonist concurrently with the GCSF, is there any concern that the neutrophil recovery will be delayed?
So that's a great question, and that's exactly what we did in our auto transplant study. So as you know, a dose of GCSF post-transplant day 1 is standard in most patients undergoing an auto transplant. And we gave the TPO receptor agonist the same day, post-transplant day 1, the same day as the GCSF, and we showed there was no adverse impact on the neutrophil engraftment, which was very reassuring. We kept a very close eye on that. It was very reassuring. So at this point in time, there's no evidence of any adverse impact. Maybe there may be a positive impact, but we don't know that. But certainly it's reassuring that it's safe.
Thank you. The next question is whether we can give TPO receptor agonists in patients with cancer-associated thrombosis who are on anticoagulation.
Great question. Obviously, any cancer represented But again, we haven't seen any evidence of recurrent thrombosis at a high rate. The very first patient I treated, literally the very first patient, that 87-year-old gentleman, he had a DVT from his chemo. And we put him on Maxipam, and he was stayed on Maxipam for 3 years and never had a recurrent clot. So if there's a risk of increasing the risk of thrombosis, I gotta believe it's very small, and our risk of thrombosis so far is so small we can't even